This is Jerry Hesch. This is my treatment room, and this video is presented by the Hesch Institute, and I'm treating an attorney who has had extensive work over the past several years or past decade, and I'm showing you the bottom of her x-ray, and unfortunately we're in the process of cleaning all our carpets, and my viewing box is not easily available, so this might not work. Okay, so then you can see the image of the pubic joint at the bottom, and it doesn't visualize the entire pubic region, but you can see that there's a distinct width at the front of it, and I'll show you another image or two. And her pubic joint has not been evaluated, although she's seen multiple practitioners, and with the exception of a prolotherapist who did in fact do prolotherapy to the SI joint, and he was a very, very thorough practitioner in terms of his hands-on evaluation and joint treatment. But otherwise she's seen a lot of clinicians who do manipulative therapy and lots of physical therapists, etc., etc. And then here's just another image making the same statement that is distinct increase in width. While I would like to say that it has kind of a craggy appearance, I really can't say that because right behind it is the lower part of the sacrum and the coccyx down there, so it does obscure it a little bit. But the reason I wanted to film this case is because this is a very athletic individual who has general laxity throughout her body. She does not have any foot or ankle pain, but she does in fact have laxity of the ankle joints. I think you can readily see that play, and she has the same play over here. Her saving grace is how very active she is, but she does qualify as having hypermobility syndrome, as joints throughout her body display hypermobility. I just want to quickly show her pelvic presentation. In supine, she has great hip range of motion. I can take up the slack and spring her right ilium. I can do the same thing on the left. When I isolate the pubic structure from above, she is rather symmetrical across, but the anterior posterior dimension is not symmetrical. The entire left face, the entire left pube is posterior. So when I come across from the right to the left, there's a step down, and that is at the upper, middle, and lower third. And of course, when I do the opposite, there's a process of climbing up. Now, I think you can readily see I'm on the right pubic bone here, and I'm imparting a force that is perpendicular to the angle that it sits at. And I am taking up the slack trying to, but it's so rigid it doesn't move. Now I'm on the fibrocartilage, and you can see that I can induce some mobility by springing it, thrusting it forward. I call these orthopedic stress tests. I'm doing the same thing on the left side. I can distinctly take up the slack, and I can spring, and you can see some subtle movement that goes through that structure. On the right side, it's stuck. Can I have you lie on your stomach, please, now? So the pattern is named a posterior left pubic bone. It's glided along its entire length, and that's described in the Hesch Institute literature, but it is not recognized in the body of literature, which surprises me because it is somewhat of a common finding. The pube bone connects, of course, to the ischium, and in prone, her left ischium is prominent, and when I try and spring, I'm putting a fair amount of force and nothing's happening. On the right side, same lower third of the ischium, I can take up the slack, and then I can impart a force and create movement. Okay? With this pattern, because ischium is posterior, it causes tension in the sacral tuberous ligament. That ligament is right here. There's no bone in this part of the pelvis, right here, and it feels like bone because it is so tight. The right sacrotuberous ligament is here, so I'm palpating across the fibers. There it is, strong structure, but you can in fact indent it and spring it, okay? The sacrum, with this pattern, typically rotates to the left along the entire face. So it's not a torsion, it's a rotation about a vertical axis. So here are the PSISs, and if I come and slide onto the sacrum at S1, 2, and 3 on the left, there's no give. If I slide across midline to the right, I can take up the slack and I can spring it. Okay? So she also has a left posterior ilium. Now if the right ilium was stuck anteriorly, then this movement would be absent. But I can actually take up the slack in this direction and I can spring it. So she does not have a true stuck anterior ilium. Now a lot of times these patterns have nothing to do with the SI joint. On this individual on the table, I submit that this is a true pubic joint dysfunction and that it is a true sacroiliac joint dysfunction. And oftentimes these things get overdiagnosed. But when there is a distinct shift at the pubic joint and you intervene and that changes, I think that that's as strong as evidence as we can have in the clinic. Anyway, I'm not going to belabor that point. There's all kinds of arguments pro and con out there, and oftentimes it's crazily overdiagnosed, and in another extreme, as in this individual, crazily underdiagnosed with some practitioners. On the left side, however, I can't rotate that forward, and that qualifies as a posterior ilium, which further explains why the sacrotuberous ligament is taut and why that ischial is more inferior. And if we look at her rib cage, the way that the sacrum compensates is that the trunk attempts to counter-rotate, and the area of compensation ends up being at about T3, T4 area, and I can get only the slightest spring mobility there. Over here, mobility is very free. If I walk across the street, I can spring these ribs very readily. Okay? And when I come on the left side, very limited mobility there, very limited mobility here, but rib number 2 moves freely. So it's like rib 3 and 4, and they present as deep on the left side. So they are countering this left rotation in which the left side of the sacrum is prominent. Would you go ahead and line your back, please? I'm going to quickly show you what happens at the anterior ribs. And I don't have a long cord. Again, we're cleaning all carpets and prepping this house for painting and such, so I can't get a perfect camera view, but this rib is prominent. This rib is prominent on that side, and then number 2 is symmetrical. And you'll notice that I cannot spring this costocartilage on this side very readily. So that's how the body compensates. It counter-rotates. Therefore, this doesn't need treatment to restore the mobility because that's a reflex. It's driven by the sacrum. The treatment is going to be done to the sacrum. So I'm going to now show you how this inhibits strength in her trunk muscles and actually in a lot of muscles. Just for curiosity, I'm going to arbitrarily test strength in her foot rotators. So I don't want you to let me rotate this foot outward, okay? You ready?
Okay.
Okay, go. Don't let me do it. So that test's rather strong. Same thing here. Don't let me rotate this one out. That's easy. And sit up, please. So we're not including any identifying features for face and such. So she's facing away from the camera. And we'll be done with this filming in about 30 seconds or so. Less than a minute, I promise. So what I'd like you to do is fold your arms on your chest. And I want you to rotate your body to the right. Okay? So the front of the body goes to the right. Don't let me break this. Hold it there. really easy for me, and your whole body gets unstable with that. Okay, you compensate. Okay, this way, please. So don't let me fight it. Don't let me push it. Hold it, hold it. She's very strong. Let's go to the right again. Give me everything you got. Hold it there. She immediately lifts up her left hip. She compensates a lot. So this shows that the trunk follows, for the most part, follows what the sacrum is doing. But there's a small group of muscles in here, small portion here that counter-rotates it. So we'll stop filming her, and we are going to treat her, and I'm very confident that we can make a big difference. And part of the treatment, after correcting the mobility deficits, will then be to stabilize it, part of which will be wearing not a sacroiliac support, but rather wearing a pelvic support at the level of the pubic joint, because that's the joint that primarily needs compression, at least based on the x-rays. And it's well known that treating the pubic joint is oftentimes all that is needed, even if there's a secondary SI instability, at least among orthopedists who treat pelvic trauma. I'll stop filming. Thank you.